We will get started, and we don't want to delay the start because this is where we get our marching orders. Our wrap-up panel is on a call to action for vital directions in health and healthcare, and we have, as part of the panel, or as the panel, to help us identify the roadmap to the future and the key elements that we have to pay particular attention to on that journey. A terrific panel. Don Bradley who is the moderator, will introduce them. Don, by the way, is consulting professor at the Department of Community and Family Medicine at Duke University, School of Medicine, and core faculty of the Duke Margolis Center for Health Policy. We heard earlier this morning from Mark McClellan, who's the director of the center, and he's been very helpful to us, as has Don, throughout the course of the organization. And he will introduce Nicole Dozier, Julie Freischlag, Josh Dobson, and Gary Salamido, and Lynn Hollowell. Thank you very much, Don.
Great, thank you. So it's right after lunch, so the first thing I'm going to have you do, I would like everybody to stand up and find the person to your left or to your right. Go ahead, find someone. Right here. Introduce yourself. And I'd like you, okay. Okay, we're done. If you can hear me, clap once. If you can hear me, clap twice. Great, okay. So, don't sit down. What I'd like you to do very quickly is to describe what your key learning from the summit was to date, and what are you going to do with it. But you only have 1 minute, so go. Okay, let's go ahead and sit down and we'll get started. Great, so at least I know you didn't start asleep. So thank you. We're the final panel of the afternoon, and it's after lunch. So really one, thank you for being here. Actually, it's probably more than I might have anticipated, but it's great to see you here. This is an amazing event, and I do want to take the opportunity to thank both the National Academy of Medicine and Dr. Zhao in particular for bringing the attention to North Carolina, and to Mike McInnes. Our panel, like others, met virtually prior to coming to the conference, and we were greatly facilitated by Jessica Marks, who's been our angel in terms of keeping us facilitated and on point. Each of our panelists will offer a perspective, and we're going to go into questions fairly quickly. So let me first introduce each of our panelists. To my immediate left is Nicole Dozier, who's a 23-year veteran of the North Carolina Justice Center, which is a statewide anti-poverty organization, and she's the director of their health advocacy project. To her left is Dr. Julie Freischlag, who's the CEO of Wake Forest Baptist Medical Center and the dean of the medical school there. To her left is Gary Salamido. Gary Salamido, who's the president, and my order on my paper was a little different than that, president and CEO of the North Carolina Chamber. Immediately to the left is Representative Josh Dobson, who is a 4-term state representative for the 85th District. Representative Dobson chairs the Health Housing Standard Committee and serves as vice chair of the House Standing Committee on Appropriations, Health, and Human Services. And finally, we have Lynn Hollowell, who's the director of the healthcare division of the Duke Endowment. It's a Charlotte-based private foundation supporting philanthropic interest in both North Carolina and South Carolina. So it's a great panel. I really look forward to hearing from each of you. Now, one of the things I want to do is to kind of set the theme, and fortunately I don't have to come up with anything original. It's really trying to synthesize what our great speakers throughout the last day and a half have said. And I think there are 4 of them. The first is that equity matters. Dr. Burhouse asked us a question yesterday, is that what do we really want to do? Is it about improving health care, so on and so forth? And I guess what I would say there is if we don't improve equity, we won't improve health. So equity was one. And the other was that Alicia Cole, Dr. Cole, said something I thought was really important. Are we tired of disparities, and are we willing to work on them? And I think that's a theme as we go forward. So equity. The second is humility. I think, and not just racial, ethnic, cultural humility, which we talk about a fair bit, particularly in the public health side, but also medical community humility and academic real-world humility. So that engaging others, before we, engaging our ears before we engage our mouth is, to me, one of the key issues. And one of the sayings that I've heard in communities that I've worked with over the last 4 years is from the a project called Practical Playbook, is, and it's on the web, so it's no big news, but nothing about us without us is for us. So it speaks to the panel before about community engagement. And it's not just, again, as the panel said, it's not about just listening. It's about really being a part of the process. And finally, I'd like to have our panel and all of us move from kind of the why and what of health to the how. We talk a lot about what's wrong or what's right, why it's that way, but what we really need to focus on is how to do it. And finally, to kind of move from individual social needs to social risk and on to social drivers. And by that I mean most of us in the healthcare arena deal with individual patient needs, and we will identify social risk and try to deal with them. But what I also think we need to keep our eye on is what are the drivers of those needs? So that, is it the zoning policies? Is it the overabundance of fast food? So those are the kinds of things that I'd like to focus on. So with that, I'm going to turn it over to Nicole Dozier. And really, the question I told her I would ask her is from a justice perspective, since it's the North Carolina Justice Center. What do you see as the key priorities?
Thank you. So I'll start out talking about our mission. It's essentially to work ourselves out of a job so we can do other things with our lives. And so because when you do anti-poverty work, it becomes a part of you. And as a person of faith also, I just feel like it's just one of my assignments. And so our mission is to attack poverty at its roots. And with that in mind, I think about a couple of points related to something that W.E.B. Du Bois talked about was like the problem of color is like a 20th century problem. And I want to suggest that we remain in the 21st century still having the same problem and really in all rooms not wanting to have an honest conversation about it. And oftentimes people of color have more of the burden to talk about it and bring it up. And so if we don't focus, though, on racial inequities and disparities and how they disproportionately impact us, but the whole community, then we're not going to be able to change the outcomes that we're trying to change. The people who have the poorest outcomes often are the people who have less financial resources and opportunities and feel like their voice doesn't matter as much. And they're not voiceless. They do have voices. We just need to listen to them and amplify them. And the second thing I would talk about is this whole world is having a conversation about, quality care. But I say that we are still in our country. It's a great country. It's the greatest country, in my opinion. But still, we're having this debate as to whether everyone in this country should have access to quality, affordable, equitable, comprehensive health care. And for me, it's not a question. It's not a debate. So I'd say that those are the key things for me is we need to start having a conversation about whether we believe it. And we don't really believe it because we haven't done it. So that's where I would start.
Well, I just really appreciate being here as well, too. I've only been in North Carolina now 2.5 years. You can tell by my lack of accent, I'm sure. But I'm a vascular surgeon, and I trained at UCLA, so I spent 20 years in and out of California. I was a dean at UC Davis in Sacramento before I came here. And I also was born in small town Illinois, so I came from a small town, Decatur, Illinois. But also I've lived in Milwaukee and Baltimore and San Diego and Los Angeles. So when I've looked at healthcare across the country and how it's developed, there's a lot of similarities, even though the towns are a lot different. When I trained in the 80s, those were the times of discovery of what you could do in healthcare. So we were just devising new interventions. That's when you could bypass your heart, bypass your leg. And we didn't know whether it was going to work or not. We just wanted to see could you feasibly do it. I remember doing the first liver transplant in 1983 at UCLA. We didn't think about why you needed it. We just tried to figure out, could you have it? So over the last 30 years now, we've figured out we can do lots of stuff, and that's what intrigues students and residents. That's why I went into vascular surgery. But now with data and figuring out who benefits most, how do you prevent those diseases? And as a vascular surgeon, we just thought we were doing a great job. We saw everybody that showed up for clinic. We treated them equally. I worked in the VA for 35 years, but we didn't think much about those that didn't show up. We were busy, right? We were doing those things that we did, and it was scary, devising all these amazing interventions, and we're still doing that, new interventions to take care of people. But at the same time, how do you prevent that? Because now they're so expensive, right? If we want to give everyone the best quality care, not everyone can have a bone marrow transplant. Not everybody can have a liver transplant. Now we're going to be able to make a liver out of your own cells. There's going to be all these amazing things, but we got to get a bunch of people that don't need it. So as a medical student dean, as I take care of 145 medical students in our first year class, of which 40% are from North Carolina, but 60% of my class comes from out of state, trying to get them intrigued and energized. We talked about that yesterday, to go into the rural areas, to be that primary care doctor. How do we get them with their informatics and all the things they need to do? I mentioned yesterday that we're going to revitalize pathology because now it's going to be part of artificial intelligence. How can we get these young people to want to go look at these social drivers so that everybody doesn't get sick? Telehealth to me is huge, being able to reach out to people, just like with my son. I text him every day, and if he doesn't answer, I'll do something horrible like call him. And then if you look at all the new generations, when I rounded with my intern today, or my fellow, because I did an operation yesterday at High Point, it wouldn't even, if I called her, she would freak out. So I texted her, how's Kayla? Kayla's fine. She went home. I mean, they wouldn't even think of that. So as you go through these generations of the high touch, high peace, these new kids actually think that was a touch, that she actually talked to me as we did that. And using teamwork, we never worked with PAs, NPs, and all that. When I trained, it was all for one and one for all. I was one of those every other night in hospital. If it didn't kill you, you survived pyramidal programs, not microaggressions, macroaggressions when I went through. You shouldn't be a surgeon. And just yesterday, if you're on social media, I posted a picture of my operation yesterday, and it was 4 women vascular surgeons. Well, you can't find that. And so here you are. And the last thing I'll talk about is really looking at the humility. Us academics, we're having to work now with many doctors who aren't faculty, not only to deliver care to the community of Winston-Salem, but to teach. And how do you treat a non-faculty versus a faculty? Who's doing research and who's seeing patients like we heard yesterday all day? That's a big tension going on because you can't deliver health care with those that do research. You really need doctors who see patients and nurses who see patients every day. And that's a big friction where we are. And the last thing I'll tell you is, I get to get a presidential intern each year, and they finish Wake Forest University, and they get to spend a year with me as CEO and dean. They mainly do financial things, but some want to end up being doctors. And I'll just tell you about the one last year and the one this year. The one last year, Dom came to us from Norfolk on a full ride to Wake Forest University, African-American, wonderful young man. And the day before he worked with me, his brother was killed in a drug deal up in Norfolk. He didn't even tell me. And his sister has 2 kids, and she's not quite 22, and she's on her own. And where does he get his resilience? I thought I taught him a lot during the year. Boy, did he teach me a lot. I took him to every single one of my meetings to hear about what it would be like if you were the medical student and you were that. He got into 7 medical schools, but of course, Wake, we didn't even interview him because he didn't have a Step 1 score high enough, so I was really embarrassed about that. We're changing that. So he's at Case this year, and he texted me, of course, he didn't call me, he texted me, and said, there's only 3 black men in my class. And I said, well, Dom, there's only 402 black men in medical school this year. And so we've got a real issue with putting, we're doing well with women, lots of women in medical school, 60%, a little bit of uptick in women of color, but we are failing with men of color. Now, my presidential intern this year is Austin, and she's a white woman from Pennsylvania. But as I've gotten to know her this year, her dad left her mom before she was born. Her dad came back when he got sick when she was about 6 and died of cancer. Her mom never got more than a high school education and got disabled when she was in high school. So she's on her own, full ride at Wake Forest. And before I took her into the operating room, she said, well, I can't go to medical school. It's too expensive. And I said, well, first you want to see, do you want to go to med school? So now she has the passion. She wants to go to med school and going into a post-bac program. How do we get Austin, through medical school with no resources whatsoever? Even though she has a great undergrad education. So part of it is touching these kids really early so you can help them, and then also understanding their risk and high issues. So I'm really want to listen to you because, as you know, we're probably going to start a new med school in Charlotte. It's still a little bit it's not quite done yet, but I think we will. So it's brand new, so we can do anything we want. It's going to be a branch of Wake, but we can do anything we want, and I would love everybody's input.
Good afternoon. It's a real privilege to be here and see some old friends and make some new ones. A little bit about the Chamber and a little bit about me, and then there's 4 key areas that we're looking to as we focus on what our role is in transforming healthcare into a value-based system. First of all, I'm a pharmacist. I'm a rarity in Chamber world. I'm a health professional by education, practiced in both hospital and community pharmacy for a little bit as I worked my way through graduate school, and then got into the association side of things and worked at GlaxoSmithKline for 19 years before joining the Chamber. So I went from the most trusted profession, arguably, to the least trusted profession, lobbyist. one rung below a used car salesman, I think, sometimes, if you listen to the media with it. So I have a unique perspective. The way you look at the world and the way you attack problems is different because of my healthcare training. First, do no harm. Use data, diagnose, treat, assess, and do it all over again with it. And that same approach is what I've taken through my career as someone who's in public policy, someone who worked for associations, worked for a major pharmaceutical company, and now is working for business, a broad-based business group. So who's the Chamber? We have a very diverse membership, size, industry, focus, beliefs, and everything that you can imagine is in our boardroom of 61 folks with it. We have some former board members here. Victor was on the board, I think, just when I joined, or very, very, very near then when I joined in late 2011. So whether it's the size of the company, whether it's where they are geographically, we have every corner of the state we have a member. We have local chambers, so we have single proprietors, and we have Martin Marietta, and we have Glaxo, and we have banks. So we have a very diverse membership upon which to draw upon about what is best for North Carolina and what are the key challenges and issues facing our state. That also, while very rich, is also a really delicate balance on a lot of stuff. And so we have to continually engage, and we hear a lot from our folks with it. So how does that fit into healthcare, and how does that fit into what we think our role and what we feel our role? And for me as the chief executive, what I'm told my role is by my members, because I work for a membership organization, we got 3 broad buckets. 2 of them are intrinsically linked, and arguably the third one. The first is education and talent supply. How are we doing to make sure that our young people and our citizens of all ages have the training, the skills, the education, not only to get the jobs of today, but that there's a reliable pipeline for the future with it. We have a business climate, competitive business climate bucket where healthcare sits. And you can get everything right on your business climate, taxes, all those things, but if you don't have talent and you don't have an affordable, predictable, value-based healthcare system, you're at a competitive disadvantage. And if your state's at a competitive disadvantage, it means people are at a competitive disadvantage to grow jobs and retain jobs and attract jobs. If you have a job, you have healthy communities. If you don't, you don't with it. So our look is holistic there, and we have to do a lot with healthcare. Healthcare and education and talent are really very similar. So one of the key roles that we play is becoming a translator for non-healthcare companies and non-education centered groups and advocacy groups, the education community at large, as how do we translate between business entities that are not in that space, not in healthcare, and those folks that are professionals in that area that are doing really great work. We need a common language, so our role is to try and find that common language, to be a translator. And what we found is that strategic supply chain management principles begin to apply, and it's something business understands, and it's something healthcare organizations understand, and the provider community understands. So we began to talk in those terms, never depersonalizing it, but just trying to find a common language about, we have everyone in the healthcare supply chain talking, but we're not aligned. We don't have a common goal yet. And to be honest, we're all pointing fingers at each other and saying it's somebody else's fault. We were talking about that briefly when we were standing up. And the time for finger pointing is done. The time for action and leadership is now. And we have a great state, great resources. We have differences geographically. We have differences among patient groups. We have a lot of differences. However, all the skill, all the talent is here. Do we have the will is the fundamental question for it. So as the chamber, our role is, A, to be an equal partner in that supply chain, not only to be in this, but to lead. When you look at the resources that are available to pay for health care, they all come from people that are working or employers, because either through tax dollars, state and federal tax dollars, through premiums, through employee contributions, through taxes. It's coming from somebody who's working or an organization that's paying taxes with it. So we have to be an equal partner at the table and arguably have a responsibility to re-engage and catalyze change into a value-based system that helps us have better outcomes at a more predictable price. And I'm not only saying lower. It needs to be lower in some cases. But the most important part for business of all sizes is predictability at the end of the day. And if it's more, but someone is getting better and they're not going to engage in the system, that's okay. If it's wasteful, that's not okay. So we have to have those conversations. So our role here is to be an active partner, to lead, to arguably take back our rightful spot that we, as a business community, actually forfeited and ourselves said we don't want to be a part anymore. We're going to hire somebody to do that for us. And even though we're paying the bill, we're going to pay somebody else to manage that piece of our business for us. And when that happened, we forgot that we have a responsibility to drive value, to drive better outcomes, and to get predictable costs. So I'm encouraged by the dialogue that's happening in a lot of places We have a number of folks that are here that are on my board, so I hope I'm doing okay today. I'm a new CEO of about 7 weeks with it. We look forward to it. We look forward to those hard discussions because people of goodwill can have hard discussions when the goal is clearly defined and the best interests of the people and the state are there. So I look forward to the panel today and to being an active part.
Thank you. Thank you so much for allowing me to be here. I currently serve Avery, Mitchell, and McDowell counties in the western part of the state, a very rural area of the state. And based on my accent, I have been here for 38 years. Three things really that I see that are critical for North Carolina and what my top priorities are and what I've wanted to do in healthcare in North Carolina, particularly in the General Assembly. One is access to care in underserved areas. As I said, Mitchell County, where I represent, has 13,000 people, and that population is declining every week, every month, every year. And if we don't have providers that are willing to go into those underserved areas and those that can make it financially sustainable, we're going to continue to have problems in rural areas of our state. So access to care is a critical issue, not so much here where we're at today, but in a lot of rural settings in our state, we have real problems there. The second is broadband. In Avery County, which I also represent, has 17,000 people. The high school that I went to, Avery High School, 1 out of every 2 students at that high school does not have access to high-speed internet in their home. That's unacceptable for North Carolina. We've talked a lot about online high school classes, online courses for high school and even junior high students, and I'm like, great, sign us up, but let's get high-speed internet across North Carolina first. And that leads right directly into the healthcare piece with telehealth, telemedicine, telepsychiatry, the things that we have to do there. But unless we can have access to high-speed internet across the state, we're going to have those challenges in healthcare. So that's a second priority that we've got to get to. And I'm sure you all, I know you all have talked a lot about it already, but I'll kind of give you my perspective on it. And that's closing the coverage gap. I want to talk just a second about that. Carolina Cares to me makes sense. Whatever group I'm talking to, policy-centered or politically centered, I talk a lot about that. Chairman Lambeth, who used to be the CEO of Baptist years ago, has put forth a plan that makes sense to me. And if we can set the ideology aside on both sides, then I think we can get to a better place. But that continues to be a challenge. And part of that challenge, or one of my priorities with that, is just educating people on what we're trying to do with Carolina Cares outside of our world that everybody knows and everybody talks about every day. When you sit down and explain to people that Medicaid is a 65-35 split in North Carolina, but with this new program with Carolina Cares, it's a 90-10 split, but the 10% does not come from the state government. It comes from an assessment on providers that the providers won't, because that's less charity care that they have to provide. We all know that, but the outside public doesn't know that. So that's a challenge to try to educate people on what we're trying to do there. And then once you do that, people are like, okay, that makes sense. So I guess that's what I'm trying to get to, is educate people and then try to find a way for both people on both sides to set aside their ideology to get to a better place on closing the coverage gap. On the right, just the whole idea of covering more people has to be part of the discussion. And on the left, there has to be a transaction. It can't be a free handout. It has to be work requirements, and it has to be a premium. The political environment that we're working in, outside of that, it's not going to work. So that's a challenge that I've had. That's something that I've been working on, and that's some of my top 3 priorities. So access to care, high-speed internet for telehealth, telepsychiatry, telemedicine, and then finding a way to close the coverage gap that makes sense for North Carolina.
Well, good afternoon. It's been great to listen to and be a part of the conversation over the last couple of days. And I think it's really, for me, kind of energizing to see how much consensus there is in the room in terms of kind of where we are now, the shift that we need to make, and where we need to go. So I think, the point of this panel is for us all to think about, what's it going to take? What's our role and the role that we each can play in kind of getting to making that turn and getting to where we all want to go. So, in private philanthropy, we think about that all the time. Again, just to kind of put the Duke Endowment in context, we're a private foundation in Charlotte, North Carolina. We fund in a number of different areas. We fund in North and South Carolina. And specifically in healthcare, our broadly stated objective is to improve the health of the people in North and South Carolina. And as we do that, also having an eye on health disparities. So thinking about how we can improve health and improve health for all. So when we were originally established in 1924, our founder, James B. Duke, gave us some broad direction as to where we would begin in achieving that objective. And for him, it was all about giving us a directive of focusing on access to care, specifically access to care for vulnerable populations. So that would include the poor, the uninsured, folks that have systemic barriers, racial minorities, people that live in rural communities. So that's really the heart and soul of the Duke Endowment. It always has been, and I think it always will be. It'll be an important part of our work. But over the years, Mr. Duke also gave us the latitude to really shift our focus and our strategies as the environment shifted, and he was wise enough to understand that it would certainly do that. So as that has taken place, we have begun to focus more of our resource proportionally into the area that we refer to as promoting healthy lifestyles. So really, these are all the non-medical components. They're things like how can we create good, healthy behaviors, physical activity, and nutrition. How can we also think more and more about the social drivers as we've been having those conversations today. But really, as we've stepped back and we continue to ask ourselves, how can we really, as a private foundation, have the most impact? We have this fundamental theory of change in terms of, it's not really groundbreaking, but access to medical care when you need it, coupled with the opportunity to lead a healthy lifestyle. Those two things happening simultaneously is going to give you your best chance at being healthy. But when we talk about humility, I think that's something that we have realized at the Duke Endowment. There are certainly limits to what private philanthropy can do. We're considered to be one of the larger private foundations in the Carolinas. The grant-making budget that I have annually in healthcare is $45 million to invest in the two Carolinas each year. And that seems like a lot of money, and it's a significant amount of money. But when you think about $45 million relative to the healthcare spending in North and South Carolina, it's north of $165 billion, you realize that we really cannot scale or sustain anything. And so we got to really rethink our role. What we also don't want to have happen is that we fund some really good programs that achieve some great things, and then the grant money runs out, and then they go away, and maybe we leave things a little bit worse than if we hadn't ventured in that place at all. So really, our third strategy, where we're increasingly focusing more of our energy, is around saying, how can we at the Duke Endowment really advance system reform? Because all of the things that we've been talking about over the last couple of days, I think we all realize we've got to make changes to our healthcare system in order to be able to accomplish all those things. So for us, that looks like, how can we invest in innovation? How can we think about some of the things that we haven't always traditionally thought about as being an important piece of the healthcare equation? How can we take risks, really, that others don't have the latitude to take? And, it's really a great environment to be in, and that our board continuously encourages us to take risks. I've had board members say to me that, Lynn, if all the grants that we're making in healthcare are working out, then something's wrong because we're not taking enough risks. So with that unique position, we do need to invest and sort of act as that venture capitalist that might be able to fund some really promising programs. But we understand that as we do that, we also have to invest and align that with rigorous evaluation. I think Karen DeSalvo talked about kind of the squishy evidence that might exist presently for some good funded programs. And I think she's right. I think what we've begun to think about is that if a lot of the objective in our grant making around advancing system reform is to promote learning, it's to create that sort of real world evidence that's then going to inform the policy conversation and inform everyone thinking about how can we change our payment schedules and our payment methodology, then we need to invest in establishing the type of evidence that's really going to be able to stand up to that rigorous criticism and appropriate criticism. So we need more rigorous evaluation, but as we think about that also, we also understand that there's a huge sense of urgency. We may not have the time to do randomized clinical trials and repeat that as often and as frequently as we'd like to, because those things can take time. So how can we create real-world evidence and do that with a sense of urgency? Because at the end of the day, private foundation funding is not going to really be a sustainable model.
Great, thank you, each of you. So you talked about system change. I guess I'd like a comment from each of you. Is that how would you change the system if you could? And I'm going to kind of go down the line again.
Thank you for that question. I think it still go back to what I started with, is that the systems that were created in this country were created to have some people who have and some who will not. None of us living today created those systems, but we certainly are beneficiaries of them. And so I think doing things like we're doing today, having real conversations, and always keeping people at the center and being closely tied to people. So in this work, I have met a woman who is from Western North Carolina. Now, mind you, it's going to be cold outside now. It's going to be winter. She has pancreatic cancer. She is a young woman. She's younger than me, and she lives in a tent. And she came to meet us because we really work to have authentic relationships with people. And I felt so bad. She came in pain to Raleigh to meet with her lawmakers, to show them what someone in the coverage gap who could lose her life because she's unemployed, uninsured, and no home, a tent in Western North Carolina. So I think remember those stories, and so which is why I hired someone who was a filmmaker to take over what I was trying to do to tell the stories. We met an individual who used duct tape to keep themselves together because they had a break in one of their limbs and was afraid to go to the emergency room. So there's a breakdown in the system, and so and on the final story I will tell you is you have a mom who is at a very low income, because if you are Medicaid as a parent, you have extremely low income. And so, but if she gets a better job, which I think she's qualified for, then there goes her insurance for her children and for herself, and then her child. So if she gets too much money, too much income, which is ridiculous, then they are not going to be able to keep their Medicaid, and she has one that will age out and has diabetes. So tell me how it makes sense that in the system that we have children worrying about their parents. So I have met children who have lost their young parents, and I have met young adults who lost their older adult parents because of just the worry, the way the old system was, the bad old days of rescission and pre-existing conditions. And if you're born with a certain condition as a child, you have a lifetime of worry and anxiety if you're not able to be covered. And this is something the Affordable Care Act did help to fix. It's not perfect. It needs help. We need to expand it, and we need to improve upon it, and we need to fully implement it through expanding Medicaid. But those are the things we should start with, is talking to the folks. If you can't tell me a few people that you have talked to, the people like I've talked to, and I'm in Raleigh, then that means, connecting with people and really listening to the stories. We put them on cards, we put them on video, and do film showing, so you can figure out how we connect with them to break down these barriers in accessing care. I don't think it's that hard. I think start with the people.
Great, thanks.
I was in Sacramento when we did expand Medi-Cal in that state, and 5.5 million people got insurance that we didn't know, and UC Davis is a safety net hospital. So we thought we knew the people that were going to get insurance, and so we were just ready for them to flip over. But we met all these other people because Northern California, the size of Pennsylvania, is very rural. Also, a lot of migrant farm workers, and we met a lot of people, but a lot of them were 60-year-old white men who were farmers and ranchers who never went to see a doctor because they were embarrassed about health care, and we admitted 40% of them. So for 18 months, we went crazy, hypertension, diabetes, along with some urban in Sacramento, but mainly rural. And then many of the other workers didn't come because they were not citizens. So we still had disparity because they didn't feel comfortable coming in either because of all the activities about not being legally in the country. It was great because after about a year and a half, we got them into systems. Outpatient Medi-Cal is not real good in California. The pay is very low, so it's hard to find providers, but using federally qualified health clinics we were. But inpatient, it really helped so that we had a good margin in the hospital, so we could take care of those that had none, but it really had good impact. So as I came to this state, there is a great benefit for that because we are paying those federal dollars and they're going to California and because in other states where they are. So I totally agree with that we need that expansion. The other system I'll tell you about is Cuba. So I got to go to Cuba 2 years ago as part of the American College of Surgeons, and they're smaller, but about the size of our state, 11 million people in Cuba. And they don't have good tertiary and quaternary care. They're not allowed to use anything made in the United States, so they don't really have CT scanners and operating rooms you would want to be there. They don't have a triage system, so if you get hit by a car, there is no ambulance similar to Africa. But they have the lowest infant and maternal mortality rates. And so if you look at them, they divided Cuba into 11 sections, and there's a doctor and nurse in each section. And if you're pregnant, you have to go see them every week. And you just go there, they take your blood pressure, they make sure you're eating. And if you don't go, grandma yells at you. That is the real system, is that grandma yells at you. And grandma makes you go there. And so they're able to have their kids and they have great primary care. Now, many of their physicians leave the country to practice to Africa to make money. There's a lot of stuff that isn't good about Cuba. And when we got back, you can't go there anymore. But there is a piece to that. You look at our state, could we do community interventions access like faith health? We have a big faith health community through churches where people go. Not so similar about the woman with pain, but those with mental illness, they'll go to their church, they trust them, and they get into our system through Faith Health or through our free clinic run by our students, and there's one at High Point too, or through your churches. And we have a mobile van now in Winston that's driving around the town to take care of the homeless. In the morning they're at schools giving vaccinations and treating asthma. And in the afternoon, we're seeing people and actually giving them food, because as you know, during the week, kids have food, but on the weekend, not so much. So I think the community piece is one piece for that initial intervention. And then in my big hat as a CEO, the system we need to do is that you get your health care close to home if you are in these small communities in Western North Carolina. Can you get into App Regional? Can we make sure you can be seen there? And if you're too sick, I get you right to Wilkes. Or if you're at Hugh Chatham, they connect to us by telehealth, and we'll do a consult on what antibiotic you need and do you have pneumonia. And we keep you at Hugh Chatham till you think you're too sick to move. And then you come to Winston, because my hospital's full all the time anyway. So there's no way you can get in unless you do need heart surgery. And so can I set up a system that you can stay close to home till you need to go? And that's what you'll be seeing us do with our system and even our bigger system, and the other systems are doing that too. So I think it's the system once you need something to be better, but certainly having places for people to go that grandma will yell at you, whatever that grandma is, and everybody needs a grandma. And if you don't have one, we need to find one that yells at you to go get what you need done.
Three things that we hear from across the board is data is the great leveler, and it should be treated as a common good, not as a commodity. So whether that's large business or small business, particularly acute for small business, data is the leveler. Data is what it is, and then you can build solutions and collaborations when you can have good, reliable, it's not perfect, but people can agree on what is happening with the data. Small business has a unique challenge in that because of appropriate privacy laws, small businesses don't have access to their healthcare data. So we're an employer of 23 people. Our premiums go up double digits, 21, 22, 25% a year for our employees. We pay it at the chamber, but I don't know what's going on. And so we can't aggregate lives in order to look at a broader group of data so that we don't infringe on anybody's privacy about what's happening, but small businesses don't have access to the same tools because they don't have access to data because we can't aggregate lives in this state. Now, we do have an association health plan that is a step, but it's in the courts. So data is the great leveler for us. Think big, but act small. Every community is different. Every region is different. We need to have some principles that are data-driven, demand-driven approaches. People need to collaborate, but act small, one community at a time. And that is going to be the key, I think, for substantive, sustainable, true transformation into the systems. Principles are going to be equal, but circumstances, comorbidities, things are going to be different in every community, east, west, and in the middle. And the last thing that we're asking our members when they look into their communities is get caught doing something good. When I first joined Glaxo, our CEO was walking around. He used to walk around and talk to folks, and he'd say, Gary, I said, well, what can I do to contribute? And he goes, catch someone doing something good and then tell people about it. So there's good going on in the state. There are good systems. There's the systems we're looking for, the value-based systems are there. There's examples, there's pilots. Let's talk about what's working so that other parts of our communities in our state can say, I want that. And that the people that can drive substantive change begin to say, okay, now I know what it is, and I can talk to somebody. So get caught doing something good.
I want to bring a legislator's position on this, or maybe a different approach, and talk about changing the system. I want to talk about changing the political system because that's where I'm at. And I've got about 14 months left in the General Assembly. I'm running statewide, so my time is coming to an end in the General Assembly. But the brokenness of our politics is something that scares me and worries me going forward. So I'm going to talk about changing the political system for a moment. Defense Secretary Gates, when he was Secretary of Defense, testified that the biggest threat to national security was not the Taliban, it was not Al-Qaeda, it was the debt and the gridlock on Capitol Hill. I would argue here in North Carolina, one of the biggest threats to us moving and continuing to move forward in health care is the gridlock at the Capitol, on West Jones Street, and at the Governor's Mansion. The most basic function, I always try to be on the level, good, bad, and ugly. The most basic function of government is to pass a budget and have one signed by the governor. We have not done that in North Carolina. This is a policy discussion, so I'm not going to cast blame other than to say there's plenty of blame to go around for everybody for where we're at in North Carolina. But the brokenness of our politics in North Carolina is something that we have to change and something that we have to fix so we can continue to make the investments in North Carolina that have to be made. And as a side note, we get to a place where sometimes ideology and partisanship is rewarded, but I think in the end, most people are hungry for a kind of politics that sets that aside and tries to find a way to come together and tries to find a way for common ground. And that's what I want to try to do with the time that I have left. My friend, Representative Craig Horn, as I was thinking about this, from Union County, tweeted this out, and this has kind of been the mantra that I've tried to have and something that I want to try to do to get to your question, to change the political system. He said, we no longer reach consensus because we no longer debate. We launch personal attacks, we scorch our opponents and preclude compromise. We brush aside possibility that a person with whom we disagree might be right. We focus on what divides us, seldom acknowledge what unites us. So that's what I want to try to do with the time that I have left, is find a way to bring us together, unite us, so we can move North Carolina forward when it comes to health care. So that's the kind of political change that I'm trying to make.
Great.
That truly is an important part of the equation. You know, when I think about systems change and what's it going to take, unfortunately, I don't think there's any one like silver bullet solution. I think we all kind of recognize that. You know, fundamentally, I think if you want to change healthcare system or really any system, you change what you pay for and how you pay for it, and then you know the system will evolve. So we already have talked in a lot of ways about the waiver program and the Blue Cross program and other ways that as value-based payment comes in, I think that creates a driver for a lot of the change that's going to happen. But also thinking more specifically about something that I think will in particular make a difference, and something I want to lift up is thinking about the healthcare workforce. A lot of the social drivers and the other things that we've talked about that really have a profound impact on health are areas that that may be a bit neglected in terms of the workforce supply and the education that we give to that workforce. So thinking about kind of these, what might be quasi-clinical positions of a community health worker, of family caregivers that really are the front lines in the home, and they need, we need more of them, and we need to think about how we can best equip them. And, you know, we have funded a number of community health worker programs, community paramedicine programs. One of the things that they see when they go into the home, and they do a lot of this hot spotting where they'll look at data and they'll figure out who are the patients that really are fragile. We're seeing a lot of recidivism in the hospital system, and they are who demographically you might think they would be. There may be elderly folks living in rural communities, and when they go into the home, you know, they see a lot of what can't be seen by just looking at the electronic health record. They see what's creating the poor health conditions, so they may recognize that, yes, we need a wheelchair ramp, they don't have access to good food, but really in addition to and maybe above all of those social drivers, one of the things that the community health worker or paramedic may come back and speak about that's fundamentally just screaming at them is that oftentimes it's social isolation. There are people that are sitting home alone all day, and they don't have a lot of things, but one of the fundamental things they don't have is just someone to engage with and talk to. And so that can create kind of a sense of depression. That can create a lot of things that create this downward pull on someone's overall health. And some research has just come out lately that said that loneliness really has the health impact equivalent to smoking 15 cigarettes a day when you compare it to other, you know, risk factors, and it's even greater a risk factor than that of obesity. So I think, you know, as we continue to expand our thinking about what really creates health, we've got to think about the healthcare workforce that may also involve church volunteers, it may involve neighbors, it may be assessing for need on a variety of different fronts that we haven't thought about, and then thinking how can we engage and think more broadly around what a healthcare workforce looks like and how we can best support them.
Great. So let me just make a comment of trying to pull a couple of these things together. Gary, one thing you said was talking about how particularly small business is a part of the community. And yet, I'm not sure that's who we, particularly in healthcare or even a lot of the health-related work that gets done, looks to businesses and particularly small businesses. So I think there's an opportunity for us to broaden the definition of community. That, you know, and it's not just, you know, it's not just the public health department and the health system and community-based organizations, but it's also business, it's the faith community, and so on. So to me, trying to think more broadly and then working to collaborate in a multi-stakeholder collaboration is something that we really need to really broaden our scheme, because health is really not just about any one segment. Julie, I saw you. Yeah.
I couldn't agree more. I mean, it affects everybody wherever you work, in every family, and small businesses. You know, when you look at the jobs that are available, every industry segment has a multiplier effect that is an indirect job that is dependent on a larger business. So it's a symbiotic relationship. If in the healthcare space, which I'm most familiar with, but even in others, it was a 5-to-1 multiplier effect. So a direct healthcare job in the life science area, in particular in the healthcare, produced 5 other jobs that are in various industries, various pieces, and most of those are small business jobs. That's less than 50 employees, a whole lot more less than 10 with it. And the more rural community, the more the community is outside the collar counties of a major metro area, the smaller the businesses tend to be, with the exception of 1 or 2, perhaps a large advanced manufacturing facility, a healthcare system, or an agriculture-based system, an agribusiness with it. So a lot of the jobs are in larger businesses, However, a lot of the new jobs, a lot of the jobs that are the most fragile are in small businesses.
I was just going to comment, we have Innovation Quarter in Winston-Salem, which is trying to stir up more small businesses for our town, because as you know, the banks just merged and we're going to lose some bank people again. And actually us looking at a new medical school in Charlotte has made everybody anxious, that we're leaving Winston-Salem. So we just partnered with the Chamber, which you probably know, with Mark, to offer a product that we've done with a legacy, which is called WellQ, which is a way to get access sort of to an urgent care and also for your chronic conditions for a couple $100s a year that you can go in. It's right downtown. You make all your appointments online and you're able to get your care. And then also you get to figure out if you don't take care of your diabetes, what it will cost you financially. That's where a legacy comes in if you don't do it. How many hospitalizations will you have? When will you lose your leg? And actually, just like with your kids, if you actually make it about money, sometimes they actually do what you say, even though, because I've tried to look for the app to make patients do what they're supposed to do, and you can't find it, right? And this has actually been good to show the future if you don't care for yourself. So we've been working, we just announced that this week, because the small businesses, for all the reasons just said, they can't get the health care, and they're scared to get the health care. The other piece I'll tell you, in our little towns too, the healthcare industry has saved Lexington and Wilkes. If the hospitals went down, nobody would have jobs because the manufacturing's gone. So keeping those 70, 80-bed hospitals full with ancillaries and then adding a few small businesses have been really essential. And the last thing I'll say is that the loneliness thing, I really was shaking my head, because the other persons that are lonely are the 20 to 35-year-olds on their devices. They're the loneliest generation we see, and suicide rates have really escalated in that population as well, too. For all the reasons I was teasing about my son, they don't talk to people, and they don't go out, and they stay on those devices and get addicted. And so that's a loneliness group that we're actually bringing up that feel very comfortable being by themselves and as they get older. So I think that's another piece, is trying to engage that group that really thinks that the device is their friend.
Great. Representative Dobson, I know you talked earlier on our phone conversations about integrated care.
Yeah, I'll be glad to touch on that. That's a personal one, so I'll tell a little bit of a story. So when we passed managed care in North Carolina in 2015, we basically punted on integrated care. We had physical care, but left behavioral health to be operated by the LMEs. That's what we did in North Carolina. Secretary Cohen comes in 16, and I was in a weird place because the House felt like we were comfortable just focusing on physical health for the first round of managed care and punting on behavioral health for 4 years. Secretary Cohen come in saying that we needed to have integrated care before we could go live with managed care. And ironically, the Senate, the state Senate, who is seen as the more conservative chamber in North Carolina, was also saying we need to integrate care. So we had the number 2 at CMS under the Obama administration and the conservative state Senate both saying we needed to have integrated care, and me and those in healthcare in the House were kind of stuck in between. It didn't make a lot of news stories because it's not a real sexy topic to talk about. But when we integrated care in North Carolina, or if we can ever get to managed care, we did pass a bill, House Bill 403, I would encourage you to look at it, that set up a standard plan for most of the Medicaid population that would fall into that standard plan, and the managed care companies would focus on both physical and behavioral health for that population. But then for the most vulnerable individuals in North Carolina, there would be what's called a tailored plan, which would be managed by the local management entities or our behavioral health entities that we've already set up in North Carolina. So I know that's a little bit in the weeds, but one of our most proud moments that we had where we actually do work together was to get to a consensus on integrated care for the Medicaid population. Now, I'll throw a caveat in there. As most of you probably know, we don't have a budget in North Carolina, so we can't go forward with managed care. It's been permanently or at least indefinitely delayed, so we'll continue on fee-for-service for a good bit of time until we can find some type of consensus on a budget. So that's a lot. I'll just say that I'm proud of where we're at on integrated care for the Medicaid population, and if we can ever get a budget done, I think that'll be to the benefit of providers and to the Medicaid population.
Great, thanks. So let's go ahead and see if there are questions from the audience or comments.
Thank you all for the excellent panel. I was struck by the comment made by an earlier speaker about if it's important, you need to meet at least once a week. If you were going to start an initiative that was going to meet once a week, what would that thing do to move us in the right direction? Because I think we all agree what needs to be done. We all agree why. And we talked about how we would get to how, but it's still a little mushy. And I would love to know concretely, what are we all going to walk out of here doing differently?
I'll just jump in. We need to get people together and agree on a common data set so you know what's going on in your community. If you and we have never met before, have we? That's step one. Level it. It tends to take the biases out, whether they be personal, whether they be disease related, whether they be political. The data says what the data says. And then people can come together and say, how are we going to attack these problems in our community? So there's people doing that. And so the second thing is, okay, you get that. Now what do I do? Well, these 3 communities over here that had a similar problem, and here's what they did. So you go out to someone and you say, I need you to be part of this, and engage. We cannot let perfect be the enemy of good. So get agreement on data, and then just call people up and come together and say, what are we going to do about this? Let's not get caught trying to fix everything. Let's fix the one thing that the data says is most hurting our community.
So I would take a different approach, if I can, real quick on that, and say what would we agree does not need to be part of this group? And that would be the first thing that I would talk about. And one would be, if you're here with simplistic solutions to the complex health problems that we have, then you're wasting all of our time, because there are no simplistic solution to these complex problems. The second thing I would talk about is saying there's no silver bullet. And it frustrates me in politics to say, if you just do this one thing, then everything will be solved. Or if you just reform CON, or if you just do this, or if you just do that, then everything's solved in North Carolina. There is no silver bullet, and we would have to come to a consensus on that. And finally, when it comes to health care, I think you have to set ideology aside, because if you come in with a rigid view, you can't solve problems.
Can I follow up on that? Would you say that Medicaid expansion is seen as a silver bullet?
I do, as someone, that's a great question. I actually had it in my notes, didn't get to talk about it. I do see that false narrative out there. As someone who supports closing the coverage gap through something called Carolina Cares, that is a fear that I have, that there is a narrative that says if we just expand Medicaid, then all our woes in North Carolina will be solved. And I don't see that as accurate. So I do, to answer your question, I do see that as a flaw.
And I think what we saw in California, it did solve the inpatient hospital problem. So it actually paid those bills, and those patients didn't have huge bills when they leave, and they didn't get bankrupt, because when they had to have their heart bypassed or needed a kidney, they could do it. But we still had day-to-day access trouble. We still had people not getting preventative care. We still had people with stigma with mental health disease. When I went to Sacramento, there wasn't one inpatient mental health bed because they closed them all in the recession. So I think that's really true. And so mine would be, one, I want him to go past the budget. I think that would be a really good thing. And then we could go forward with Medicaid expansion, but we need to continue every week to go out there and keep touching patient one by one by one in our community, whether it's the van, Faith Health, our free clinics. Now that we're expanding our region to expand our touch, and those would be those people right on the front line. And I go out and actually go do town halls all over, so they touch them there, and then they come into our hospital system. And then my job is to teach the students I teach to understand that's where they should be, and that's where the first point of health care is.
And I'll just add that we work a lot with coalition partners, so there's no way you can be in Raleigh and really work across the state without having to be connected with people who are in the communities, which is better anyway. But an example of something that we did in June was we did 22 simultaneous vigils across the state, because we know that's a tactic, that's an activity that people are aware of what that is. They're aware of town halls, they're aware of press conferences, but a vigil had a different feel for us. and the focus was to honor the lives of the people who died who were uninsured. And so what we did is we started out saying we'll do 12, and then other people came to us saying we want to do it. So we created a toolkit, and it included everything you need to know about how to do a vigil, how, here are some stories of people that are in the community nearby you may not know. And we mailed to all the locations everything they needed to do to hold a vigil, because we can't be in all those places. And so at the end of that, the New York Times actually covered our vigils and did a video op-ed about that. We earned over about $1 million of earned media, and were picked up by dozens of outlets. And so I think that's a way to get awareness out there. We had the data and things, and on reports, so like the Cone KVR report about how many people would get coverage in your area, how many people in the Affordable Care Act and got subsidies. Only 90% of the people in our state get financial help or subsidies who are on the online marketplace. So that's an activity that we did to honor the lives of people, and then how does that group and that community continue to go forward? And we've continued to reach back with those same folks as new organizers and new supporters of expanded access to people in North Carolina.
Great. So I want to throw a couple things out. One is it would be interesting for all funders, be it NIH, CDC, philanthropic, the legislature, to require that people meet once a week. I think now, and we say, oh, that's a waste of time, that's meetings. I mean, we've heard that particularly in my life in the business sector. But I think multi-stakeholder collaborations, one, should be another requirement, is that you can't do this on your own. And I think part of the meeting piece of that is who are the right people to be at the table. I think the other piece of it is who's not at the table that ought to be.
I think, you're making a great point when we think about all of the alignment that we've been talking about over the last couple of days. It has to take place, and it has to take place locally within community. What we're not really adequately supporting is the infrastructure locally dedicated. Folks have referred to it as a backbone organization. Whatever it looks like, you need some intentional investment around what it's going to take to bring people together. Somebody has to see that as their full-time job. Because especially if you want to get parity amongst in terms of influence of all the different organizations that need to be represented at the table, you can't just sort of deem one organization as being king of everything. I think we've got to think about how we can intentionally invest in the infrastructure that's going to allow for, I don't know if it's weekly meetings, but regular meetings where folks can come together and really work together.
That's great. Are there other questions? Dr. Zhao.
Well, this is all music in the sense that the stakeholders in this session and all the others I've heard the last 2 weeks are to a large extent aligned in their vision, right? So as I think about Representative Dobson, I think you'll make this issue of political will. Question is, we live in a democracy, and people are elected to represent them at the state or at the federal level. So what would it take for this voice of all of yours together to be sure that the people hear the alignment and obviously the right vision is for their health? What would it take to get to the level whereby the people who are going to make decisions on behalf of the citizens, if you will, are going to make the right one together in aligned fashion?
Yeah, that's the million-dollar question, right? What would it take to bring people together politically to actually do the right thing for the people of North Carolina and the United States?
But let me just put a fine point on this. Unless I'm missing a large group of people in this space not attending this meeting and have very negative feelings about this, I'm hearing that you guys all sing from the same song sheet, right? But if that's the case, isn't that a great voice that you can all put forward together?
Well, I hope so. There are different voices at the General Assembly for sure, and with the.
I'm sorry, I don't mean to
Yeah.
interrupt you.
Yeah.
I mean the people who actually are doing the work, delivering the care, who care for the patient, who understand health of the community. I'm not talking about the politicians in this legislation. They are only elected there to represent the people, so the people have to hear what we have to say here. What would it take?
So, okay, I think I see what you're saying now. I think a couple things. We have to stay engaged in the process. We have a consensus here. We are in it every day. We work on these things, and we know what things we could do to achieve success in North Carolina. I think that relationships matter. I think that knowing your legislators, knowing your congresswomen and men is critical, because you can't wait until something's come up in the General Assembly or something's come up in Congress to say, oh, wait, this is a problem, or, oh, wait, this is a good thing for North Carolina. It's easier if those of us in this room, those of us across the state who have a stake in this, provider groups, advocacy groups, whatever, build those relationships on the front end, so when the time comes and the lights come on, that we can all try to work together because we already have those relationships. A lot of times in my 7 years in the General Assembly, I've seen that a bill is introduced, or you see something having traction that you either support, or let's say you don't support it. There will be people in my office saying, this is bad, this is why you should vote against it. But it's hard for me to have some level of credibility for them to have credibility with me if I didn't already have that relationship. But if it's someone, either a constituent or a lobbyist or whatever it may be, that we've built a relationship, when they come in my office and say, this is a bad thing for North Carolina, this is a good thing for North Carolina, I think it helps. So to answer your question, we can't wait till something comes up. We have to build those relationships amongst each other now, and also amongst our legislators and our congressmen and women.
Just to add to that is, you know, the best lobbyist is a constituent. People in Raleigh are only there representing an aggregation of voices, regardless of who you're representing. The folks back home need the people they go to church with, they see in the grocery store, the people they work with. That's the best lobbyist. So now that's really difficult, because we as a society, we the people, when you look at, we think a good voter turnout is 33%. So in any district, regardless of where you fall, 51% of 33% of the people eligible to determine who goes to the North Carolina General Assembly or any election, and it goes down into the teens for local elections, as you know, there's a whole lot of people not participating, but expecting a different result. So the answer to that is, you know, one conversation at a time. But if someone says their vote don't matter, they're just wrong. It's not right. It's not the right narrative. And all of us as individual citizens, regardless of everything, have the obligation to say, we the people want this. And 51% of 33% is not good. So I don't know how we attack that other than one conversation at a time. We could start at Thanksgiving next week when we're with family and friends, you know, or you know, maybe, or after the second glass of wine.
So can I?
But that's
Don,
what we're committed to do.
Don, may I?
Yeah.
You know, if you look at all the various surveys and studies on trust in science, and the most recent one is from the Wellcome Trust, they look at 100,000 people over 100 countries. Health and medicine always come up to the very highest. If you look at the funding in NIH, despite whatever efforts to cut it, Congress supports it. What I'm saying to you is you have a collective voice. I mean, I understand you need to one person at a time, but there's a collective voice that need to be heard, in my opinion. And the collective voice is so strong here the last 2 days, and you trust it. You're the healthcare providers. You're the people in the front line trying to do the right thing for the people. You're doing research to find cures. All that stuff, tremendous credit, in my opinion. I'm just asking the question whether the public is hearing enough from us.
And I think
Collectively.
I think we need to tell stories. I think we're sort of a humble group. I think the whole state is. You know, we're just so polite, unless we try to merge on the freeway, and then this state is crazy. You just merge. But otherwise, they're really nice to do it. And like today, there was a baby that was brought into our hospital last night, and because we gave them a free car seat when she had the baby, and the baby's 1 month old, the baby was not injured in a big crash because this car seat was part of a deal. We just started delivering more babies at our hospital. So I asked them today to put that story out, all out there, saying this person got a free car seat because they got a free car seat and they had that the baby wasn't even injured in a major crash. So I think a story at a time, saying thank goodness and then we had the policy that we need the money for these free car seats to make that happen. It may be simple stories, you know, it could be a bone marrow transplant, but this one was a baby that got saved by a program. So I think lots of stories to take everywhere. We can post them, we can put them on the internet, whatever we do, because the story is what's so, her stories were just hurt, you know, so you really want to take whatever your people, now we had to ask them permission to put the story out, right, to do it, and there's a piece of HIPAA that sort of hurt us, you know, because HIPAA was important, but I think sometimes it makes us pause and asking, can we tell your story? And if we could tell more stories about where good and what sadness it is, I think that could be helpful.
And I would also add, I love doing diverse panels and having different perspectives, and because there is alignment like you spoke about. I do think, and I'll speak because I'm also a local elected official, I do totally agree with you about people engaging with you early on about things. And so sometimes it's hard for people to know how to find out things. And so, you know, I think communications is what we choose to use, but everyone's not on social media. Some people actually are socializing face to face with people. But so in our town, we try to put things on the utility bill. You know, you can either add it to it or type it on there. Those are just things, because everyone is not on the internet all the time. And so I think in district things are easier for people to get to have to come to town halls or small meetings, whatever it is. I try to do film showings. We have a 9-minute film of people. We have a farmer who is a veteran who is teaching veterans how to farm, because veterans and farmers have high suicide rates. So telling those stories so people can then share those stories when they're talking, saying, oh, I'm one of the 13,000 veterans who's in the coverage gap. So that's what, I think we should try to do. Duplicate this, but do it in district. Or in Raleigh, it's a little bit challenging for people to get from Silva but we do have a woman who did come to Raleigh. But you got to support people when they're taking off work to come to Raleigh too.
I'm going to echo that I really enjoy the diversity of the panel, and it really, what I always find is when we meet face to face, I come up with new ideas, and hopefully other folks are as well. And what gets brought to mind for me is it came from your comment about loneliness and depression. One of the best ways to mitigate loneliness and depression is to express gratitude and to find things that we have in common. And I think if we all started with, once a day, and particularly when we're meeting with someone with whom we don't necessarily agree, is, are you grateful about any one thing that this person, other than, I really like the red top, substantive, what's the gratitude and what do we have in common? And then once we have something in common, can we work together? And particularly when we have multiple folks at the table, I think it really moves us forward even more dramatically. So, any last questions?
Just a quick comment. I'm Caitlin Phillips. I'm the managing editor of the North Carolina Medical Journal. I've communicated with several of you. I was going to say, since you brought it up, to Dr. Zhao's comment and question about the collective presence and communication, we are doing an issue of the journal related to this symposium, and most of you will probably have an opportunity to contribute. Everyone who writes also has the opportunity to get several copies, physical copies, and everything goes online. So the more everyone, you're welcome to share those copies in your communities and ask for extra ones and share them around. We do a lot of social media outreach, so that could be an opportunity. I just wanted to make sure everyone's aware of that and invite everyone to share it when it comes out next year.
Great. So what do you need from each other? We've got a diverse table. What do you need from each other?
I will just say that I don't see myself as a policy expert. I see myself a lot of times as a facilitator of policy from those who are in it every day. So I welcome input as a legislator. I welcome knowledge. Julie knows far more about the minutiae and the nuance of the clinical side and the policy side than I will. So I welcome those comments. I welcome those comments from you all because I'm in a position to facilitate it, but I don't have all the answers. And the only way I can get and have that discussion is to hear from you all, and that helps me to try to be a better legislator.
And I would agree, more communication about what we all do. And I was a little nervous having a politician on the panel, but hearing how much you care, just everybody really does care in our positions.
And I guess I would like for folks to really think about some of the points that I raised related to equity, and to, if you're in a position to be an ally, that you consider how to do that, and reach out to me if there's things that you want to learn or talk about related to that. So that's what I would appreciate from folks.
Anyone else? Okay. Well, I think we are right at time. I think we should thank our panel because it's been a great